Hi, my name's Damian. I'm a consultant in Paediatric Emergency Medicine in Leicester in the UK. This is a short presentation designed to help new doctors in our department manage the feverish child. Kids with fever cause a lot of anxiety, both for parents but also for doctors and other healthcare professionals who are examining them. It's mainly because we all know that every so often some cases of serious bacterial illness are missed. This creates a great deal of anxiety. So I've put together some pointers based on some of my own experiences and also some evidence to help decide what the best thing to do with that child is. In the UK, much of our evidence for managing the feverish child comes from the NICE traffic light system, which is part of the NICE guidance on managing the febrile child. This is a really useful document which I recommend any junior doctor or healthcare professional has had a look at some point early in their attachment. I don't wish to go through it in fine detail, but there are some key points I'd like to pick out. The first is that fever itself is not a discriminatory feature of illness, i.e. the height of the fever doesn't tell you a great deal apart from in a few select scenarios. If you're less than 3 months and you have a fever, that is a huge red flag, and you should always seek senior advice. If you're between 3 and 6 months and you have a temperature of over 39 degrees, that does put you in a slightly higher risk category, and it's always worth treading with caution with these children. Furthermore, any child who has a fever for 5 or more days has a slightly increased risk of having a more serious bacterial illness or some very specific conditions such as Kawasaki's disease. The method of obtaining the temperature is important. NICE guidance does not recommend the use of a forehead thermometer strip, preferring an infrared tympanic membrane thermometer or a digital thermometer that is used under the arm. Unlike our colleagues in the continent, in the UK we don't often measure a temperature via the rectal route, although there is a good evidence base to support this as well. It's really important that a thorough history is taken. But during that history, you must really listen to what the parents are telling you. Often, the parents are more worried about the fever than they are the child. In my experience, the children who are most at risk of having a serious bacterial illness are those in which the parent is unsure why they are worried about their child. They just have a feeling that something isn't right. The parent who is able to explain that they are very happy with the child and only worried about the fever, I think, are at less risk of having something more serious. However, obviously, you must perform a further examination to confirm this. Having taken the history, you need to do an examination. But it's really important that not only do you do your examination, you really look at the child's posture. Their interaction with the parents and their interaction with you will give you a lot of information. The child who is very distressed and can't even be comforted by their parents, to me, is of slightly higher risk than the child who actually is easily comforted by their mother or their father. One of the reasons that we give antipyretics for children with fever is not because we're too concerned about the temperature itself. It's because we want to see what the child is like when they are less miserable. Having a fever makes you miserable. And what we want to know is what the child is like when they have had the painful nature of the fever taken away from them. The child who remains quite miserable despite having had some antipyretic may be of higher risk, although the recent evidence review in the NICE fever guidelines didn't confirm this is a good test for whether a child has a serious bacterial illness or not. Finally, it is important not to pay lip service to the location of the source of where the serious bacterial illness or the virus that is causing the fever may be. It is important that when you examine a child, you expose them fully. You will only be able to find that rash, which may lead you to a diagnosis of meningococcal septicemia, if you have completely exposed the child and looked underneath their legs and at their back. It is important that you learn how that the parent should hold the child so that you can have a very good look in their ears and a very good look in their throat. There is no child who will be able to resist enough that you can't get at least a brief look at the back of their tonsils to see if there is pus there. And finally, it is really important that in the child where you can't find a source of their fever, that you have made an attempt to dipstick their urine to look for the presence of a UTI. So, as well as your normal history and examination, please do look at the NICE fever traffic light table and ensure that while you are taking the history, you are really listening to the parents, that when you're examining them, that you are making a good look at their behaviour and that you make all efforts to locate the source of that fever. If you can't find the source of the fever, but the child meets all the characteristics of green on the traffic light table, then those children are safe to send home with appropriate safety net advice. Obviously, if you are ever unsure, you should ask a senior for advice. Managing the child with a febrile illness is as much an art as it is a skill, but it is something, with due care and attention, that you can become a very skilled practitioner at. Many thanks for listening.